Welcome, everyone. We're so glad that you're joining us. Can you please advance the slide?
Oh, yes. Oh, wait a minute here. Okay.
Awesome. I'm Sally Smith, and it's my pleasure to introduce you to your presenter today, Tami Anastasia. Tami is a dementia consultant, educator, and speaker. She's also the author of the acclaimed book, Essential Strategies for the Dementia Caregiver, Learning to Pace Yourself. Tami holds a Master of Arts in Counseling, a certificate in gerontology, and a certificate in end of life. She's also a certified senior advisor. For more than 30 years, Tami has provided counseling services, dementia guidance, emotional support, and care strategies to family and professional dementia caregivers. She also facilitates twice-monthly support groups. Tami will be taking your questions at the end of her presentation, so if you have questions during it, please just go ahead and type them into the chat, and we'll get to them at the end. And now, please join me in welcoming Tami.
Hello, Sally, and hello, everybody. Thank you for attending today's webinar. I am going to begin my presentation by going over a few things that I think are really, really important for you to remember. One of the first things you want to keep in mind is that a person living with dementia, they have dementia, and dementia is impairing their brain. It is damaging their brain. The brain cells are shrinking, and because the brain cells are shrinking, it's going to alter your loved one's perceptions. It's going to alter their thinking and alter their reality. So that means they're going to say and do things that may be incorrect, that make no sense at all, that may be inaccurate, may be hurtful. And you want to keep in mind that they don't have control over the things they say and do. This is truly a symptom of dementia. And another thing you want to keep in mind is, as dementia progresses, it can become increasingly difficult to get your loved one to act in ways that support their well-being. It can become very difficult to get them to do things that you know that would be really good for them. And often they get accused as being difficult, uncooperative, or stubborn. And in reality, that is not what they're doing. What is happening is that their thinking is being altered, their thinking is impaired, their perceptions get distorted. And as their thinking changes because of what dementia is doing to the brain, we have to change our thinking, our approach, and our expectations. The person living with dementia does not have control over what is being done to their brain. And the people that have to change are us in order to accommodate their changes. And that's really important to remember, that if we change our thinking, we change our approach and our expectations, we'll find better ways on how to relate to them and how to communicate to them and even react better. The other thing I want you to remember is that all behavior is a form of communication and a way of expressing a need. What is very challenging for us as a caregiver or as a care partner is figuring out what they want us to know, is figuring out what they're trying to tell us and what needs do need. What are they needing? What is the need that is being unmet that we need to now meet for them? That is probably one of the greatest challenges that we have to figure out when they can not communicate it clearly, when they cannot communicate it directly. Now, a lot of times they will communicate to us, but we will dismiss what they're saying, we'll correct what they're saying, we'll argue. And that's where we have to change our approach. That's where we have to change our thinking. And I'll elaborate on that as we go along. So as dementia progresses, what's going to happen is your loved one will lose the ability to think rationally and to process information logically. At some point, reasoning and logic will make the situation worse. And a lot of times clients will ask me, well, how do I know if this is the right thing to do? And the rule of thumb is we'll know if it's the right thing to do by their reaction. If we have a negative reaction, we need to change how we respond to them, and we need to change our approach. If we don't have a negative reaction, then we're okay. So we need to change when we get a negative reaction, when we get an unfavorable reaction. But at some point in this journey, reasoning with them and trying to be logical can make the situation worse. So what do we do when we reach that point? What we can do is replace logic and reason with the 4Ds of dementia care. The 4Ds are to detach, document, diffuse, and distract. So I'm going to go over what each of those ones are in more detail. First D is to detach. Really do the very, very best that you can to not take it personally what your loved one may say or do. Much, much, much easier said than done. But know that any change, anything they say or do, know that's a result of dementia. And be willing and open to changing your expectations, thinking, and approach. I know it can be incredibly hurtful, it can be incredibly sad. And we have to remember, I have this dementia mantra that I have clients say all the time to help you detach, not take it personally. The mantra is, dementia is causing my loved one to behave this way. Dementia is causing my loved one to behave this way. Every time you start to take what your loved one says and does personally, remind yourself, dementia is causing my loved one to behave this way. And when we can detach, it allows us to reframe what we say to ourselves about their behavior. And when we can reframe what we think about their behavior, it can change our reaction and it can change our approach. And I'll talk about ways we can do that. The second D stands for document. And clients will often roll their eyes or just say to me, oh my God, Tami, please don't ask me to do one more thing. But the time you want to document is when you are dealing with challenging behaviors or if there's a change in medication. Those are two times that I highly, highly encourage that you document, because for as unpredictable as dementia is, there may be causes or patterns or triggers. And if we can figure that out, we could decrease the intensity and the frequency of the behavior, or we may be able to extinguish it altogether. And documentation is incredibly valuable and incredibly powerful. So I'm not saying to keep a lengthy journal, but certainly when there are challenging behaviors or there's a change in medication, I'm going to encourage you to document and write down your observations. And I'll go in more detail as we go through the different behaviors we discussed today. Diffuse is the third D, and one of the best ways to diffuse any situation is that we need to acknowledge their feelings. We need to validate what they are saying. They need to feel heard and understood. Even if you don't agree with them, even if what they're sharing with you is incorrect or it's not valid, we still have to validate what we hear them say and do. And validating isn't agreeing, it's not disagreeing. It's just paraphrasing back to them. I hear what you're telling me and I understand what you're telling me. And then we have to provide a reassuring and comforting response. Super important that we do this 3-step process. And I'll talk about that as we go along as well. And then distract. That's our fourth D. We first have to validate, we first have to listen, we have to validate, provide a reassuring, comforting response. And then we want to distract. Once we can distract them and get them engaged in a topic or an activity that they enjoy, have them talk about things that are pleasurable, have them tell you about the touchdown that they scored 100 times because it made him feel, like the superstar or the hero. But you want to have about 6 to 8 different distractions up your sleeve that you can use interchangeably that that they really, really, really enjoy, so that you can implement the distraction right off the bat, and know that you can switch them off. You can do 2, 3 different kinds of distractions, but at least have a good idea of at least what, 5 to 8 distractions are. So today, there are 4 challenging behaviors I am actually going to focus on and how to implement the 4 Ds of dementia care. The first behavior I'm going to discuss is how to deal with repetitive questions, and then how to deal with medication refusal, and which is a very, very touchy, sensitive subject, is how to deal with impaired driving, and then how to deal with sundown syndrome. So before I talk about each one of these behaviors and apply the 4 Ds, I do want to educate you on what some of the causes could be that contribute to these behaviors. So some of the causes that could be causing repetitive questions to occur is they don't realize they're repeating themselves. Because of the short-term memory loss, they're not repeating themselves because they just want to hear and drive you crazy. They really have short-term memory loss, so they don't realize that they're repeating themselves. And this is super important to keep in mind. They may be reliving a past memory, a past event. They may think something happened recently, but happened really 30, 40, 50 years ago, and they're repeating the questions because they're reliving a past memory or a past event. And then they may be in physical pain or discomfort. And that's something we always want to explore when we're dealing with challenging or difficult behaviors. And they may not remember your response. They may hear it in the moment and then they forget it. And another where I really see an increase in repetitive questions where they really ruminate is the more bored their brain is, the more I see them and I hear them ruminating. I'll often ask questions to my clients. Well, what's their day like? And the more bored, B-O-R-E-D, the more bored they are, the more I'll hear them ruminating and asking repetitive questions. So kind of think of it like this. We just went through COVID and we were all confined. And imagine you sat in a room, one room, and all there was 4 walls. There was nothing to distract you, nothing to preoccupy your mind with that would be external. What do you think would happen? What is the brain going to start doing? It's going to start ruminating on things. So it's really important that we try to keep a person living with dementia as engaged as possible, keep that brain stimulated as much as possible, provide a consistent routine, have structure in their day. So this is just something that I do notice, that I will see an increase in repetitive questions when the person doesn't have enough structure in their day. There's not enough activities keeping their brain engaged. Also, other causes is they want reassurance. Can you imagine all of a sudden your world doesn't make sense? Can you imagine how fearful you might become, how afraid you might become? Are you going to leave me? Are you going to stand by my side? All of a sudden, what's familiar doesn't look familiar, and there's a tremendous amount of fear. So sometimes those repetitive questions is they need that reassurance. They need that comfort. They need to know that they're safe and they're secure. And then they need to feel a connection to you. We're taught very, very early on, one of the best ways to connect with people is we ask questions. So sometimes repetitive questions may be their way of trying to connect with you, especially if they feel you're pulling away from them or we're not spending enough time focusing on them. And then their environment is unfamiliar. Let me elaborate on that. We know they've been in a home, the same home for 50 years, 40 years, but remember, their brain and their perceptions and their thinking is being altered. And so what we know is familiar to them now becomes unfamiliar. And so when they're in an unfamiliar environment, can you imagine their perceptions is, I don't recognize where I am. I don't think I belong here. This is where we'll hear, I want to go home. I want to go home. I want to go home, because it's unfamiliar. We know it's familiar, but we have to interact with them in a way that provides a sense of security, a sense of safety, and realize they don't recognize the familiar environment as being familiar anymore. So how do we apply the 4Ds to repetitive questions? Repetitive questions. First, remind yourself and tell yourself that they are not aware of their behavior. Often they have no clue that they've asked you 5 or 6 or 7 times, and you don't want to test them. You don't want to remind them you've asked me that question 5 times. You just want to know that this is a symptom of dementia. And tell yourself they aren't doing this intentionally to annoy you. They have short-term memory loss. They don't remember. And then listen objectively. Here's what I want to convey today that's super important about dealing with repetitive questions. When they are repeating a question over and over, ask yourself, what is it they want you to know? What is it they are telling you? Because often there's going to be themes to what they're telling you. And this is where documentation can become incredibly beneficial. So one of the first things I'll say to my clients is, please write down verbatim what your loved one is saying repeatedly, over and over and over. And often there's going to be themes. So here's what some of the themes are. They might be sharing something with you that is very memorable, super important, something they're concerned about, something they're worried about. And these are themes. And if we understand the theme, it helps prepare us on how to respond. So when you listen, I want you to listen differently. I want you to listen to understand what it is they are trying to convey to you, what it is they're trying to tell you. And then I want you to listen and see if you can figure out what the need might be. And pay attention to the emotion that's being expressed. We get caught up in the words, but listen to the emotions. Are they sad? Are they crying? Are they angry? Are they frustrated? All of this is great information that will help us know how to respond, will help us know how to provide a reassuring and comforting response. I know repetitive questions drive you crazy, but now let's listen differently because they're communicating something to us. We now need to listen so we know how to respond in a comforting, reassuring way, and focus on your loved one's underlying needs. So here's what I would like for you to keep in mind also. We all have basic human needs. Whether they have dementia or not, those basic human needs apply to each and every single one of us. So what are some of those basic needs? Well, as dementia progresses for them, they're going to become more and more dependent on you to reassure them and to provide support. They're going to become more and more dependent on you to make them feel secure and safe. They're going to become more and more dependent on you for physical comfort and care. And they're going to depend on you to validate them, to make them feel heard and understood. And they're going to depend on us for the cognitive stimulation, the physical stimulation, and the social stimulation their brain needs. And they are going to depend on us to still give them a sense of purpose, value, and importance. These needs do not go away because they have dementia. Those needs exist in the same way that they exist for us. So understanding what those needs are also going to help us know how to respond when they are repeating questions over and over. So keep in mind what the basic needs are, because that is what they need as well. So how do we diffuse the situation? We diffuse the situation by reflective listening. As I said before, we have to validate what we hear them say. And one of the best ways to validate is reflect back to them, use the exact same words that they're using. So you're communicating to them, I hear you and I understand. And then we provide a reassuring, comforting response. Two of the best ways to do that is to say, thank you for bringing that to my attention. Thank you for letting me know how you feel. I am so sorry that's upsetting. Or you might say, I can see how upset you are. But somehow you have to convey back to them that you hear what they are sharing with you, and we're providing a comforting and reassuring response. And you can also use visual cues. One of the things I hear constantly is my loved ones constantly asking me, what day is it? What time is it? What day is it? What time is it? So let's shed a little light on why they might be doing that. Think about our whole life. We have been structured since we started school. We get up, we have breakfast, we go to school, we have lunch. We have a lot of structure in our life. And then when we get out of school, we work for many, many, many years. And for many, many years, we had a purpose. We were going someplace. We were reliant on the clock. We didn't want to be late. We had places to go, people to meet, and now I have dementia. And where do I need to be? Where do I need to go? That's sort of like our body memory, right? Muscle memory. My brain still thinks I have some place to go. I have some place I need to be. There's something I need to do. So these visual cues are fabulous to work with. And we can put up a whiteboard, and we have a daily calendar where we tell them today is Tuesday, August 15th. And we write down 9 o'clock, 10 o'clock, 11 o'clock, 12 o'clock, and let them visually see there's some structure to their day. Let them visually see that there is purpose to their day, because that visual may cue their brain in as reminding them and give them a sense of peace and give them a sense of reassurance. And if you're exhausted and you point to the board, sometimes we use Alexa. Alexa, what time is it? What day is it? And these digital clocks are fabulous for people living with dementia. It says the day, it says the date, and it says the time. And some of them will talk as well. So these are all different ways to diffuse the repetitive questioning. And then nonverbal gestures. Sometimes I had a very lengthy discussion with a caregiver in one of my support groups. And I said how powerful and meaningful gestures can be, nonverbal gestures, a smile, hold their hand, rub their shoulders. These are all things that can be incredibly reassuring. And she said to me, well, I don't understand what he needs. And at some point, when they lose the ability to communicate what it is they need, you can read their nonverbals, their body language, and we can reassure them non-verbally is just as powerful, just as meaningful as verbal. So don't dismiss. If verbal, we can always go into another way of communicating and providing reassurance is our nonverbal gestures, a smile, a nod, eye contact, holding their hand, rubbing their forearm. There are so many ways we can provide reassurance and that comforting that they need and that they want. Then once we diffuse, then you also want to prepare responses in advance. So as I mentioned earlier, there will be themes to what they say. So I'm going to use a client example. So a client said to me, Tami, my mother's driving me crazy. Her mother was very, very controlling when she was a teenager, and she actually went to college and went away for many years. But she's come back now to take care of her mother. And her mother always wanted to know where she's going, when she's coming home, commented on many, many things. So now what is very typical of somebody with dementia is they're going to ask, where are you going? When are you coming home? And she's reacting as though mom is doing that intentionally. And I worked with her so that she could see that this is normal dementia behavior now. We processed what those feelings were like pre-dementia, so that we came up with 3 or 4 interchangeable responses. So when mom asks, where are you going? When are you coming back? We have 3 or 4 different responses. We don't have to keep recreating the wheel. And we can use these responses interchangeably. So sometimes when they're so repetitive and we identify what the need is, we can go ahead and prepare in advance, and now we conserve our energy and we respond in ways that is very soothing for them. So once we do, though, the listening and we do the validating, and then we provide the reassuring, comforting response, it's really important that we distract them. Many people think of this as redirecting their attention. So offer them their favorite snack or beverage, or invite them to share a story, and maybe have them help you with a task, wipe down the counter, go rake leaves, water the flowers in the back, or reminisce. So a lot of clients will often, or a lot of people living with dementia will often say, I want to go home, I want to go home. This is a beautiful time to use reminiscing therapy. This is the time where I'll say, tell me more about home. Tell me what it is that you want to do when you get home. What do you enjoy the most about your home? This is going to clue me in as to what era their brain is living in. And this is a wonderful way to distract versus saying, well, you are home. We've lived here for 40 or 50 years. Ask them about their home. What do you want to do when you get home? Do you want to go see a parent who you know has passed? Oh my gosh, I loved your mother. I remember the time, and we can distract them, get them engaged, get them to talk about things that are enjoyable, that are pleasurable, and it will diffuse that need of now forcing you to have to say, well, you are home. We want to redirect their attention, engage them, get their brain preoccupied in doing something or talking about something or an activity you know they enjoy. So these are the ways to apply the 4 Ds of dementia care to repetitive questions. Next, I'm going to talk about medication refusal. Let's look at what some of the causes might be. They're confused about why they need to take it. They might have been taking this medication for years and years and years and years, and now they are confused as to why they need to take it. Fair enough. They have short-term memory loss. They don't understand, they have difficulty now processing information. And their refusal makes them feel in control. I want to clarify that. When I say the refusal makes them feel in control, it's not that they're doing it intentionally. All they know is you're asking things of me that I don't understand, that I might be afraid of, and by rejecting it, by not doing it, I am protecting myself. Because I don't understand, I'm not able to understand. See, our perceptions are not altered, theirs are. Our intentions are well-meaning. And I really want to go on record and say, none of you are doing anything wrong. What's wrong is their perceptions are altered now. Their thinking is impaired now. And we just have to change our expectations so that we can meet where their brain is now. And so I want to make sure none of you leave here today thinking that what I'm sharing with you is enforcing what you're doing is wrong. No, we're just trying to outsmart. We're trying to relate to a brain now that is functioning differently. And they may have difficulty swallowing pills. They may refuse medication because they don't like the side effects. And they may have some dental issues. As a matter of fact, dental issues is one of the things you always want to keep in mind, especially if we see a decrease in appetite, especially if you see that they're not wanting to eat as much. But dental issues, they could have sores in their mouth. They could have a toothache. Their dentures could be poking into their gums. So these are all things to think about that could be contributing to why they're refusing medication, which allows us to reframe what we say to ourselves, and then we'll change our reaction and our response. Also, they may believe medication is poisonous. I hear that very frequently. They believe that the medication you're giving them could be poisonous. I'll ask all of you, if you truly, truly, truly believe that I was giving you something that was poisonous, how many of you would be willing to do it? You know it's not poisonous, but they truly believe that it's poisonous. So we're going to have to change how we deal with that, because if they think it's poisonous, then we're going to have to introduce medication in a different way to them. So think about, if you thought it was poisonous, I wouldn't want you to take it. I wouldn't want you to take something you thought was poisonous. So I have to, if that is the reason they're telling me, I have to change what I do in terms of how I reframe the situation or the medication to them. I have to find ways to present the medication in a way that appeals to them rather than frightens them. And they may not like how medication tastes or feels, or they may not like the size, color, or the quantity of medication. That's another one I hear quite frequently. So if you have pills and we can cut the size of the pill, fantastic. We cut the size of the pill, make it smaller, make it easier. Color, that's a whole different ball game, but we can still deal with color by camouflaging it with something else. So these are just good things to keep in mind, that when they're refusing medication, they're not refusing to make you angry, to upset you, because truly their brain is altered, it's impaired, and it's damaged. And I don't understand what this is. So they may refuse medication. So how do we apply the 4Ds of dementia care? First, we detach. How do we do that? Try not to take what they say personally. Try not to take the refusal as a rejection. It's not a rejection. It has more to do with, again, the cells are shrinking, and so the thinking is impaired. Tell yourself that there's an underlying reason or fear. Here again, when a client reaches out to me and says, my loved one just won't take medication, let's listen to the reason why. Because understanding that reason is going to help me know how to respond and present medication in a way that appeals to them. And that's the key. When we're dealing with any behavior changes, how do we know what we want to achieve? We know what we want to accomplish, but how do we present it to them now in a way that is appealing? And that is what is key. And that's going to vary from person to person. And then again, listen objectively to their reasons. They are telling us what we need to know. What do we do now with that information? How do we use that information to our benefit? And tell yourself they are not intentionally being difficult. Again, the brain is being altered. So here again, documentation comes in extremely, extremely handy. So I like people to keep what I call a medication log. You write down the date, you write down the time, you write down the name of the medication, and when they refused, what happened? What is their reason for refusal? So here are some examples. Are you interrupting them while they're enjoying an activity, and now you're saying, oh, time to take your medication, and they don't want to be interrupted? Are they refusing to take medication because you're waking them up and they're not quite awake, they're disoriented, they're confused, and now you've got to take your medication? We might need to give them more time to wake up, more time to adjust to waking up, getting their day started, and then giving them the medication. Has there been a recent change in their medication? That is huge. If there's a recent change in the medication, you want to document again the time, you want to document the date, you want to document what that change was. Did we increase the medication? Did we decrease the medication? Did we change the medication? Did we omit the medication altogether? Super important information. And then what will they take? I have many clients who will take certain pills, but they won't take other pills. What's the difference? That's what we want to look at. What is the difference? Why will they take some and why will they not take others? And are they more apt to take pills at a certain time of day versus another time of day? So that is how we think about diffusing the situation. What are ways of dealing with medication refusal? Don't use logic or reasoning. If it doesn't work, you're always going to know if a response works, because they will either respond positively or they'll respond negatively. So if reasoning and logic doesn't work and telling them why they need to take it because it's for their blood pressure and you're going to lose them. And what is really, really sad about reasoning and using logic with them, it can create a lot of tension between you and your loved one. And we already have a symptom of paranoia, and sometimes that reasoning and that logic can fuel the paranoia. Now you become somebody that they start to not trust. Now you might become that person that it becomes more difficult because they're suspicious. So we just try not to use logic and reasoning when it's not working, when it's not effective. We are going to go down the rabbit hole often. So instead, use words that are appealing. Some things that are really appealing when it comes to medication is we refer to it, it's time to take your vitamins, if that's something that appeals to them, or it's time to take their candy, the Skittles, or a Tic Tac, but anything that resonates with them. And that's going to vary from person to person, but I won't call it medication. I won't call it a pill. I'll refer to it as something else that I know appeals to them, that they're more apt to accept and take, because I am reframing and I'm rewording what it is that I'm calling the medication. Another thing is, don't force it. It's not worth forcing it, because again, it's just going to cause so much tension and strain between you and your loved one. And you're working so very, very hard to take the best care of your loved one. We need to take care of you too. And I just wouldn't put yourself in a position where you're trying to force it. Walk away. Let's try again, maybe in 15 minutes, maybe 30 minutes, and reintroduce it in a different way. Reintroduce it, name it something else, call it something else, but let's reintroduce it in a totally different way. And optimize the timing. You're going to find that as dementia progresses, they have good times a day, and they have not so good times a day, and they may have bad times a day. Well, sometimes as the day goes on and evening, for those people who have to take evening pills, taking them at 8 o'clock at night may not be the best time. But you could call the doctor and say, listen, my loved one, can I move taking up the evening pills to 5 o'clock or late afternoon? Because my loved one is able to take those pills. They're more comfortable taking pills earlier in the day rather than later in the day. So if you do make any changes, please always run them by the physician first, but optimize the timing. Like I said earlier, if giving them a pill right when they wake up and they're not going to take the pill because they're disoriented and they're just waking up, well, then we wait 15 minutes, 30 minutes and give it to them later. So try to, again, hone in on what is the best time to give them their pills, or again, their medication or their vitamins or their candy. We want to try to establish a consistent schedule, because when we do find the optimum time, that's what we want to try to stick to as much as possible. And, if it's going to be 5-10 minutes difference, that's one thing, but really see if you can hone in on when is the best time of day for your loved one, and then reduce the quantity. At some point as dementia progresses, is it really necessary we have them on 20, 30 pills? Let's talk to the doctor. Are there things that we could reduce? Are there things that we could take out? Maybe we don't have the supplements. Maybe we take out certain medications that are no longer necessary because they don't need them. And here again, you always want to check with your doctor first. And then a pill organizer. So pill organizers can be very, very helpful. The pill organizer really is to be more helpful to you as a way of keeping things straight. Not always will it be beneficial, especially as dementia progresses. But initially, in the earlier stages, a pill organizer can be very, very beneficial. So I do want to share a story. So I was given a talk, and this gentleman said to me, my wife just refuses to take her medication. And I said, well, can you tell me a little bit why that is? She goes, well, she just keeps saying, I like that blue pill box. Why can't I take the pills in that blue box? And he kept saying, well, those are my pills. Your pills are in the pink pill box. And I said to him, why don't we just switch the pill box? Let your wife take her pills in your blue pill box, and you would go ahead and take your pills in the pink, in the pink pill box. And that resolved that current problem. So we just kind of have to think outside the box. But here again, let's really hear what they are trying to convey to us, what they are telling us while they still can. Because this journey gets really much more complicated and difficult when they lose the ability to communicate to us what it is that they want us to know. And then when in doubt, we can always call the doctor, see if we can get their medication in a liquid or powder form. And then what we do is we just camouflage it in their foods. And that's one way of getting them to take their medication. So again, how do we redirect their attention? How do we distract them? Combine it with an enjoyable activity. I can't tell you how many times we may combine medication with eating ice cream. Some of my clients love pizza, and we may combine taking medication with the pizza. So you may want to try, sometimes we try to pair a not favorable behavior with a behavior that is really enjoyable, an activity they really like. And distract. People living with dementia love most, not everybody. Again, all the tips and the strategies I'm sharing with you today are all sort of generic tips and strategies because I don't know each one of you personally and individually. When I work with clients, I get that information. But medication songs or a rhyme. One of my favorite rhymes is I have an Asian couple, lovely couple. And so the rhyme that she came up with is one for you, one for me. Now it's time for us to drink our tea. And it works beautifully. So sometimes if we can find ways to rhyme what we're trying to do, rhymes work very well with some people living with dementia. And we offer a reward, any reward them, praise them, compliment them. Oh my gosh, you're just so good at, praise them, reward them. Those go a long way. They go a long way for us, and it goes a long way for people living with dementia. And then sometimes we have to take the medication together. Go ahead and do it together. It's an activity the two of you do together. We take it at the same time. That may normalize taking the medication, and it's something we're doing together. It's a connection we have. It doesn't single me out. It's some activity we're doing together. So these are some of the 4 Ds of how to deal with medication refusal. Next, I want to talk about impaired driving, and I just want to go on record now and just say this is an incredibly difficult, sensitive, very sensitive topic to deal with. And it's something we all encounter as our loved ones with dementia progress and decline. So let's just look at, some of the causes. Short-term memory loss is going to cause them to be impaired driving. Familiar routes are no longer familiar. They don't know how to get from point A to point B. There's increased confusion. They went to the grocery store that's 10 minutes down the road, and oh my God, an hour and a half later they showed up. They don't know where they were. They don't know how they got home. They got home, but they were hugely confused on how they got there. Poor judgment. And this will have, detours can become very difficult for people living with dementia. They're not quite sure how maybe to maneuver detours. Poor judgment. And then decreased attention and concentration. They're easily distracted. That, they can look around a lot more. These are some of the causes that cause impaired driving. Visual spatial disorientation. As dementia progresses, their visual field really starts to get enclosed. It'll get enclosed to a 12-inch. That's what the visual field can get narrow as is 12 inches. So here, visual spatial, you might see your loved one really thinking they're really close to a car, and yet they're hundreds of yards behind. They're driving super slow, or you'll find that they park really uneven. So it is spatial orientation, and they'll have slower reflexes. And, slower reflexes are something we all experience as we get older. But for people living with dementia, there's a gap between, what their brain tells their body to do. There's a disconnect. And so the reflexes are going to be slower. And then difficulty processing information. This is where they may not be able to read the street signs. They may not be able to read one way, again, detour. So these are just some causes that the brain, because of dementia, that happens to the brain. We all know that, but the person living with dementia may not think they have a problem. And this is where it gets very difficult and very hard. So first, how do we apply the first D? How do we detach? Put yourself in their shoes. Imagine each and every one of you have probably a belief, and you so strongly believe that belief. And there's nothing in the world that I'm going to convince you to believe differently. And if I keep trying to convince you, try to disprove and question and challenge you, at some point you're not going to like me. At some point you're going to get angry at me. Well, this is a normal reaction. If somebody has impaired driving and isn't aware of their limitations, it's not that they're in denial, it's that the brain is being damaged in the frontal part of the brain, and they're not able to see that limitation. So put yourself in their shoes. You're truly convinced you're a good driver. but we know you should not be on the road. Think about how you would like to be approached. What we do prefer first is that we notify the doctor. We want to give the doctor a heads up that you have concerns, and you may want to anonymously report your loved one to the DMV. Now, every state has different requirements. Some states, California, you can report it and remain anonymous. But these are other ways to work around not having to confront your loved one, and we prefer doing that if at all possible. And then when the time comes, they have been reported, they get a letter from the DMV, they are now told that their license has been suspended until they retake the test or whatever that letter states. Be there for them. They're going to be distraught. They're going to be upset. They're going to be angry. This is the time we have to validate what they're feeling. We don't have to solve it. We don't have to explain it. We have to give them an opportunity to express what this means to them and how they feel about it. And if you think about it, each and every one of us, one of the greatest ways we know to maintain our independence is by driving. So know that the underlying emotional layer is this interferes with my ability to be independent. Can you imagine how distraught you would be if you didn't understand why this was happening? And they're not in denial, they're just not aware of their limitations. And if it comes down that we have to prepare for the discussion, that we have to have this discussion, this is where I spend a lot of time with clients, is preparing them on how to deal with this discussion, because it's so emotional and it's so sensitive. Here's what I'll say to try to avoid. Do the very best you can to try to avoid telling them what's wrong with them, telling them all the things you see them do wrong, telling them, pointing out their limitations. That's brutal. I don't want to be told that, I did this and I did that and I did this and I did that, and especially if I don't believe it. So we have to figure out other ways to bring to their attention and other ways to find ways to make not driving appealing. And we got to be strategic in how we do that. So what are some things? So first, let's talk about documentation. The documentation for you and for the MD and for the DMV is great to have clarification on what you are seeing happening, because you can start doubting yourself. You can start questioning yourself. And that's the other thing that's wonderful about documentation. It gives you a reality. It sorts out what truly is happening and prevents you from doubting yourself. So things you might start documenting are forgets where they are going. Things you might document is that they're getting lost going to and from familiar places. Remember, this is information for you. This is not information we want to put in front of them or share with them if you think they're going to get upset. We don't want to do that. It's already bad enough that I've been told that I can't drive and my license has been taken away. Let's spare them and interact with them with some dignity and some respect in the same way we would want to be treated. Their decreased coordination. They're not able to put on the blinker and also look over their shoulder and do this. Also, we will see increased dents. We will see them go over curbs, especially those cement blocks in a parking space. And you might get a lot of neighbors or friends that say, well, I saw your loved one and they went right over a cement block. And they can't stay in their lane. Often you'll see that visual spatial, they won't be able to stay in their lane and they'll veer over. And they may have poor judgment while driving, again, ignores traffic signals and signs. So these, again, documentation. How do we diffuse the situation? Here again, we want to validate and empathize with them, what they're going through. And we want to start planting seeds in advance. You know your loved one's driving is starting to decline. Now's the time to start think about other transportation alternatives, and you do it with them. Maybe we take Uber together. Maybe we have friends come and pick us up. But let's start introducing different alternatives, different ways of getting to point A and point B. And you can participate in that with them to try to normalize that eventually they're not going to be able to drive. Sometimes we disable the vehicle or the key fob. Oh man, what's wrong with the vehicle? It's not working. We'll take it to the repair shop and we may remove the vehicle. We may give it to a friend whose car broke down, but we may take the car off the premises, out of sight, out of mind. So these are ways of dealing with impaired driving. And then again, how do we distract them? We go through the motions of helping them study for their driving test. Why not? Chances are they're not going to pass. And let's go ahead and show our support by going through the motions with them to help them study for the driving test. And we can hire a driving coach. Oh my gosh, I'm so sorry this happened. You know, AARP or AAA, they have driving programs, and maybe you'll participate in one too, and we'll both participate in one. Do the best we can to normalize this for your loved one, and we can start having items delivered. More and more items can be delivered. Start using Safeway, Amazon, and all those services that can minimize your loved one needing to drive. And then have family and friends come over and take your loved one out. Offer to pick them up when there's an event they want to go to. And you offer to drive. And they'll say, well, I can drive, and just say, well, you know, my driver's test is coming up and I want to try to get as much practice as I can. So it'd be great if you would let me drive, because the more practice, and again, use yourself as an example to try to normalize what this devastating feeling can feel for them, this devastation of not being able to drive. They will eventually adjust, but it is traumatic for both the person living with dementia and for you, because you're the one on the receiving end of how this is affecting them. So sundown syndrome, different causes. Sensory overload, oh, way too much stimulation. We'll start to see agitation. They'll get anxious. They might get irritable. Sensory overload can contribute. Nighttime hormonal imbalances, melatonin. Here again, if we're going to introduce anything new and you want to try melatonin, be sure to run it by the physician. And then not feeling safe in the dark. There are many, many people when I do a deep dive into a person's past, because it often will elevate and it will often get relived as dementia progresses. If there are people who were very scared in the dark, this is important information for us to have, because that can contribute to sundown syndrome. So how do I bring comfort? What can I say or do that's going to make them feel safe if they're afraid of the dark? Not enough exposure to sunlight, that affects the circadian rhythm of our brain. So if you can get your loved one to get anywhere between 10 and 30 minutes of daylight, would be very beneficial. But again, not enough exposure to sunlight will contribute to sundown syndrome. And then we have fatigue, low blood sugar, hunger, or thirst. And I don't know about all of you, but I know at the end of the day, late afternoon, especially kind of between 2 and 4, I get a little hungry, I can get a little irritable, my blood sugar has dropped, and I need to eat something. So these are all things to think about that could be contributing to sundown syndrome. And then they may be disoriented from lighting changes. This is where they'll see shadows, and we want to light everything up. We want to pull the curtains and not have them see shadows if possible. They may be in physical pain or discomfort, and there could be not enough structure in their day. You'd be surprised at how much not having enough structure in their day can contribute to challenging behaviors. So how do we detach? Oh, and reaction to our body language. They can become ultra sensitive to our body language, especially if it's the end of the day and they're hungry and they're irritable. So this is just, again, be very mindful of your body language. I do want to say again, it's nothing you guys are doing wrong. It's how their brain is perceiving the information. It's how their brain is processing the information. So how do we apply the 4 Ds? Detach. Tell yourself it's not your loved one's fault. Tell yourself that your loved one doesn't have control over what their brain tells them. They truly believe what their brain tells them. Their perceptions are altered because of damage done to the brain, and prepare activities in advance. So once we know what time of day that the sundown might start, we start distracting them with activities. This is where we'll give them a snack, and then I may have them set the table, and then I may have them watch a movie. But I'll start trying to distract them, get their brain engaged, to see if we can diffuse the potential of any sundowning kicking in. And then document, try to identify patterns or triggers. Here again, very useful. Write down the day, the time, what you're starting to observe, what's happening, what are the behaviors, what are the symptoms you're observing, and what happened prior to that behavior. Did something happen? Were you talking about a topic that made them upset? Did they watch something on the news that was very upsetting? What happened prior to the behavior? What were you wearing, watching, or talking about? All things to keep in mind. But that documentation can shed some light, very valuable, very good information on if there are causes, triggers, or patterns. We can intercept the behavior, we can diffuse the behavior, and possibly extinguish it. And then how do we apply? How do we diffuse sundown syndrome? Consistent routine, super, super, super beneficial. Limit caffeine and alcohol after late afternoon. Increase exposure to sunlight. Install a night light, especially when the daytime, when there's a shift in that day, dusk. Light up the house, keep the light as bright as possible. At nighttime, if they're afraid of the dark, we may need to leave lights on and or install night lights or even motion sensors if possible. Limit daytime napping. It's okay if they want to take a nap for 20 minutes, 30 minutes, but 3 or 4 hours is going to throw their daytime sleep cycle off. And then close the curtains, monitor TV watching, and again, increase daily activities. And then these are wonderful ways of distracting them, different ways of calming activities, especially at nighttime and if they're sundowning. And it's going to vary from person to person. So these are the 4 Ds of 4 challenging behaviors that many caregivers deal with. So in closing, I would like to just summarize a few things. Challenging behaviors do contribute to caregiver stress and burnout. So what I share today is really to help you conserve your energy so that this journey is not done at the expense of your physical, mental, and emotional well-being. One of the most difficult challenges the caregiver, the care partner deals with is letting go of who they were, letting go of what was, and truly now embracing the person they are with dementia. And the more we embrace who they are, the more we listen, the more we provide the comfort and the reassuring, the better we're going to know how to approach them and know how to interact with them and communicate with them. This is a grief. This is a loss. This is a sadness. To make that transition, letting go of what was and embracing what is, be patient and give yourself permission to grieve that loss and sadness. And the goal is to try to embrace your loved one now as the person they are with dementia. And dealing with challenging behaviors takes time, patience, and practice. And there is not a one-size-fits-all solution. Everybody's very individual. Everybody has likes and dislikes. What appeals to one person may not appeal to another. You know your loved one better than anybody else. So we just try to find things that appeals to them. So we get them to do the things that we know that are in their best interest. And be open to experimenting with different strategies to see what works for your loved one. Don't just give up. Oh, that didn't work. No, allow yourself to figure out why it didn't work. That's one of the first things I ask my clients. Tell me why it didn't work. Well, this, and this. Oh my God. All right, that sheds some light and we're going to try something different. Mistakes are opportunities to learn from. They're not failures. Don't get frustrated because that didn't work. Ask yourself why it didn't work. What could we try differently next time? What could we do differently next time? What can I learn from this situation? And understanding underlying issue helps you to figure out appropriate strategies. People think I'm a magical worker. I don't have any magic. What I do is I know the questions to ask. And I get such a good history and I go for a deep dive on who your loved one is and who you are and about the relationship. I learn from you, but you supply the information I need to have. And you have that within you. We just have to be open to experimenting and exploring. Give yourself permission for trial and error, learn by doing. This is a learn by doing journey. And always, always, always remind yourself you're doing the very, very best you can. Some days are better than others. A bad day doesn't make you a bad caregiver, does not make you a bad person. It just means it was a tough day and we'll try again. And be sure you reach out for support, as much support as possible, so you get your needs met, because this is a journey that can be very challenging and difficult. And in many ways, it could be very meaningful and loving and compassionate and kind. So our emotions can be all over the place. So in closing, I do want to end with this quote by Nancy Kreisman. And if you all would read it out loud with me on 3, 1, 2, 3. My caregiver mantra is to remember the only control you have is over the changes you choose to make. I want to thank each and every one of you for attending today's webinar. And I know some of you might have some questions. I apologize, I've gone a little bit longer. I want to give you time for Q&A questions. So next, I'm going to turn it over to Sally.
Thanks, Tami. We do have some questions that came in, so when we get to that part, I will read them off. So if you need guidance, if you need help navigating the challenges, Tami can help. She offers one-on-one caregiver counseling, family counseling and coaching, caregiver strategies and techniques, dementia care plan development, on-site consultations and assessments, counseling for those diagnosed with dementia, cognitive and physical stimulation for people living with dementia who are in the Bay Area. And if you haven't been a client of Tami's, you can book your free 15-minute consultation today. The URL is on the slide, but I will also paste it into the chat.
Yes, and I know how challenging this can be. I know how difficult this can be. And I also know you're doing the very, very best that you can. And I would be so honored to talk with you and provide personalized strategies that might be able to make this journey easier on you as well as your loved one. So I encourage you to schedule a 15-minute consultation appointment with me so that we can talk about your situation and your loved one.
Terrific. So when might you need Tami services? There are a lot of circumstances. If you're struggling with caregiver burnout, stress, depression, guilt, or grief, if your family's in conflict, if your loved one with dementia, or if their caregiver refuses help, if you're unsure whether or not your loved one has cognitive impairment, if you have dementia and you need guidance in navigating your journey, if you need a care plan, referrals, or resources, if you need personalized strategies to deal with your loved one's challenging behaviors, or if you don't like the person you're becoming. And we have done a drawing for a free support group session, and we did that before we started, and Kate Mack is our winner. So I will be in touch with you, Kate, and let you know how to redeem that. And as a reminder, Tami's book is Essential Strategies for the Dementia Caregiver, Learning to Pace Yourself, and it is available on Amazon and Audible. Thank you all for coming. And now we're going to pivot into questions.